Hello, my name is Dr. Shahazab Al-Anain and I'm the correspondent for MedEdge MEA at the 4th Emirates Pediatric Bone Marrow Transplant and Gene Therapy Congress happening here in the vibrant city of Abu Dhabi. I'm very happy to be joined by Dr. Mohana Reddy from India. Thank you very much for being here, Doctor, and welcome.
Yeah, thank you. It's my pleasure.
Oh, it's a pleasure having you. How are you finding the conference so far?
Yeah, it was a great conference. So it was a sort of networking of the whole all parts of the world. So many they have shared their recent advances what they are doing, especially in the gene therapy, CAR T cell therapy from the Western countries, and also how it is evolving, and also the most of the countries even from the low and middle income countries, how they are facing the sort of issues with the transplantation and cellular therapy and how to optimize according to their local conditions. So it's sort of all mix up, and it's a great learning source for this conference. It was excellently organized.
Definitely, it's a very informative,
Yes.
international meeting, and I'm very happy that you're enjoying it. And Doctor, before we dive into bone marrow transplantation, can you kindly introduce yourself to our listeners?
Yeah, so I am Dr. DM Mohana Reddy, so the program director at Sankalp India Foundation in the Bangalore, in India. So we are a 20-bedded exclusive pediatric transplant center, and we cater for mainly the non-malignant diseases, mainly in the hemoglobinopathies and inherited bone marrow failure syndromes and aplastic anemia. And also recently we have started work in the primary immunodeficiencies.
Amazing.
Yeah.
Thank you very much for sharing that with us. Amazing background, Doctor. Now, to start, can you outline what are the main cost drivers in bone marrow transplantation, and how do they impact access to treatment for children, especially in low-income countries?
So I was mentioning in my talk also that there is a myth surrounding on the cost. So many of the transplant physicians, they feel that the outcomes mainly depending on the cost of the transplant. So it's not the cost of the transplant, so it's mainly the evidence based. So even with the adequate infrastructure, so we know that for any setting of the hematopoietic stem cell transplantation unit, we need adequate infrastructure. But we should think about what we need, the infrastructure. We have to invest in the infrastructure, and more than infrastructure, we have to invest in the persons mainly. So for any successful transplant unit, investing in terms of the nursing care. So we feel, with our experience, we felt that more the units invest on the nursing care, and the more the improvement in the outcomes and success outcomes will be there in the transplantation process. So which can be done in the cost-effective way. And when it comes to the treatment part, so mainly the evidence-based treatment. So we always believe in the whatever we do, either in terms of the conditioning regimen or post-transplant care, so infection prevention or infection control. So always we believe in the evidence-based care. So what we are doing is there in evidence for applying those. So it's not about the cheap transplants, it's about the cost effectiveness, affordable transplants giving at the on-par quality.
Amazing. Thank you very much for highlighting the importance of investing in healthcare professionals as well. Amazing, Doctor. Now, what are some of the innovations or evidence-based strategies that are currently being used to make sure that bone marrow transplantation is accessible to all children?
Yeah, so at our center, so we have done from last 10 years around 800 bone marrow transplants. So around 500 transplants in the match sibling match related donor, and around 300 are the haploidentical transplants. With this our experience, we believe that mainly when it comes to one of the innovative strategies, we have published all our experiences. One is the surveillance cultures mainly in the transplants in the hemoglobinopathies. So earlier we were following for any patient admitted inside of the unit, we used to follow surveillance cultures and start the empirical antibiotics based on the surveillance cultures. But then we thought, is it necessary to the surveillance culture? Is it adding any value? Whether the outcomes are different when we start the empirical antibiotic policy just based on the surveillance cultures. Then there was no significant difference whether you follow your protocol, whatever the antibiotic policy, irrespective of your surveillance cultures. The outcomes were same. So doing surveillance cultures is adding to the anxiety, and also adding the unnecessary antibiotic exposure higher antibiotic, because we know that most of the in our part of the world, most of the gut stool cultures, we know that MDR bugs will be there. So based on surveillance culture, if you go on adding empirical the higher antibiotics, the more we are prone for the making the drug resistance and more Clostridium difficile infections in the transplants. So we published that also results that there is no role of the starting of empirical antibiotic should not depend on the surveillance cultures. So that we have published. This is one of the innovative strategies we adopted. And second is use of the GCSF primed bone marrow. So earlier the concept that the in most of the Western countries still they follow that the non-primed bone marrow they use for the hemoglobinopathy as a bone marrow source. Then because many of the donors are smaller kids, and also with the giving GCSF we can mobilize easily and the smaller volumes can be collected. And we also published that the GCSF primed bone marrow with the incidence of graft versus GVHD rates are very low, even less than 5%. So our experience says that the chronic incidence of chronic GVHD is less than 3% in our institute. We use all GCSF primed bone marrow for the all bone marrow source.
Right.
So
thank you very much for emphasizing the need and the importance of evidence-based practice. Now, Doctor, how do public and private partnerships, government initiatives, and non-profit organizations contribute to expanding the accessibility of care of marrow transplants?
This is the very important question, and mainly in the context of the low and middle income countries, because we know that approximately 80% of the families are not affordable for the even of the cost we are providing at the LMICs for the transplant cure. So we need a strategic public-private partnerships, either in terms of the support from the government or from non-profit organizations, so that we can mobilize funds and cost effectively we can implement in the transplant program for the serving of the larger population. So for example, we are one of the collaboration with the DKMS has significantly changed how we proceed with the transplantation program. So the DKMS people, they believed in us and they supported us with some financial resources and also setting up some infrastructure, and we delivered the cost effectively by utilizing those funds and delivering to the patient outcomes. When the outcomes were significantly improved, similarly many of the other non-profit organizations approached us and they believed in us that they were seeing our results, and we could take more funds from these collaborations, and we expand it to the large population control, and so that the more children are getting benefited from these organizations and collaborations. And the same models can be implemented in the newly, for example, in the now the DKMS has the program of the access to transplant, mainly the setting of the HSCT unit in the African countries. So the physicians from African countries, they visit our institute and they see how the model it works, and they are going to replicate in their countries. So it's many of the countries, they are starting these HSCT programs so that they can do at the local level of the many of the children for these hemoglobinopathies or other malignant disorders also.
Amazing. You're spreading your knowledge and experience to others, and that
collaboration is very much important.
The cause of treating children and making care accessible to everyone. Wonderful, Doctor. Now, from your perspective, how can hospitals and healthcare systems optimize their resources to improve access of care to children with cancer and make sure that all the new technologies and innovations are accessible to everyone?
So that's what we have to focus in any HSCT unit is, one is evidence-based practice. Transparency is very important, and collaboration with the different networks, so that we share our knowledge and we share our success or failure stories, so that the upcoming any other HS unity, they can adopt our success and failures, so that they can develop their own strategies. So this is very important. And it's not about only success, because we have published our in more than 30 in articles in our peer journals. So among the 30, I think 5 or 6 we have published about our failures also. It's not that whatever we do, everything is going to succeed. So we have to very transparent and tell the world that what we had failed in also, so that they can pick up those points and learn when they start the HSCT unit. And also we have to be collaborative, because we know that many of the times what we are adopting, the other centers might be adopting so much cost effective strategies also with the significant improvement in outcomes. Those we can locally adopt it, and we can improve our experience with the HSCT outcomes also. So it's very important for the collaboration and transparency for any HSCT unit to grow and to adapt to the local needs.
Amazing. Thank you very much, Dr. Reddy, for sharing your insights on this crucial matter and highlighting the importance of evidence-based practice, and also emphasizing the need for collaboration to make sure that all patients across the world have access to the latest innovations and care possible.
Thank you very much.